I present to you my poster, Thyroid Ablation for Large BRAF, TERT positive thyroid cancer and improvement 4 years after first treatment. As we all know, for thyroid cancer, surgery is the standard treatment. However, now there are new approaches that include active surveillance and thyroid ablations for microscopic thyroid cancer. Herein, we describe a patient with a 5.9 centimeter thyroid cancer who was deemed inoperable because of cardiovascular condition. Our patient is a 92-year-old female that presented in 2018 with a 5-year history of right thyroid nodule with a 4 by 4 cosmetic score, where you can see in this image on the extreme right of her neck. And she also had a positive Pemberton sign. TSH was 1.9 on levothyroxine 75 mcg per day, and she also had a positive anti-TPO antibody. Ultrasound detected a solid and heterogeneous nodule that measured around 4.8 into 5.9 centimeter with a volume of 58 ml with a regular border and no lymphadenopathy. The left lobe had two solid hypoechoic lesions measuring 1.9 and 1.2 centimeter. CT scan done showed around approximately 6 centimeter right heterogeneous lesion with tracheal deviation and mild tracheal stenosis. You can see here the CT scan images where my pointer is pointing. This is the nodule here with the tracheal deviation that can be visible. FNA of this nodule was done, and it was a Bethesda 3 with a positive TERT mutation. She was a poor surgical candidate due to significant atherosclerotic heart disease, and she declined surgery as well. In March 2019, there was a decision done to do an RFA on this right nodule. As you can see, this is the ultrasound where my pointer is, which is pre-RFA with a volume of 58 ml. Post RFA, she had a follow up 6 months later, and we see that there is a shrinkage in her nodule wherein the volume went from 58 ml to 40 ml. And she also had improvement in her symptoms. She continued to follow us later on as well. So here we have now an image 28 months post RFA, and now it shows a regrowth. The volume went up from 40 ml to 52 ml. There was no lymphadenopathy that was present at this time. But there was a decision done to repeat the FNA at this time, and we saw that the repeated FNA showed a Bethesda 6 and a positive for BRAF and TERT. 1 month later, a decision was done to perform percutaneous laser ablation on this nodule. As you can see down below here, this is the ultrasound image pre-laser ablation where the volume is 52 ml, and we did the percutaneous laser ablation without any complications. 1 year post PLA, we see that the nodule has reduced significantly in size and the volume went down to 17.6 ml. CT scan done showed a 2.6 centimeter nodule, so there was definitely a reduction in the size of her nodule, and there was just mild tracheal deviation with no lymphadenopathy. And if you see on the extreme right down below here, her neck, you can see that the cosmetic score is now gone down, where previously it was 4 by 4 in this image on top. It's now gone down to 2 by 4. So, to the best of our knowledge, this is the first large thyroid cancer with adverse genetic mutations, BRAF and TERT, that was treated with thyroid ablation because of significant comorbidities and refusal to surgery. First, the treatment was RFA, and 3 years later, with percutaneous laser ablation. In the end, now the patient is at 97-year-old and she's satisfied with the decrease in the cosmetic score to 2 by 4 and is asymptomatic. Despite the genetic mutations, she did not develop any metastatic lymphadenopathy on imaging. This case may open the door for more patients with thyroid cancer who cannot have surgeries due to comorbidities. Thank you.